Welcome to Season 3 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today I speak with Dr. Monica Burrell, the Health Commissioner of the Commonwealth of Massachusetts. Our topic is the COVID vaccine and the unique approach that Massachusetts is taking to making the vaccine available. Let's listen. Dr. Burrell, thank you so much for joining me. And I want to jump right to the COVID vaccine. How did you receive the news that we have safe and effective COVID vaccines here in the United States?
First of all, thanks so much for having me here to chat with you. And when I heard about the COVID-19 vaccine, it was the first glimmer of real hope that I felt in a long time. All of us in public health have been at this since February, nonstop, 24/7, addressing the pandemic of our lifetime. And I must say that the daily news about people getting sick and dying is devastating. And, we all work with data and we have, this 35,000-foot view. But when you think about the individuals we've lost, it's very difficult and people are working very hard. So for me, the news of the vaccine was promising. We have in public health been leading with science and data, and science is what will get us out of this. So it was really the glimmer of hope at the end of this very long, dark tunnel.
Along with that hope, was there a thought that, wow, this means the health department has a lot of work to do?
I actually didn't think of it that way. I feel honored that the Massachusetts Department of Public Health really was able to systematically and thoroughly evaluate how we would distribute the vaccine. And, the people who work with me at the Department of Public Health, like departments of public health across the country, are so mission driven and so dedicated to help the individuals in Massachusetts. They took this on in a way that, I feel humbled to work alongside them.
So it sounds like you were prepared for that announcement then.
That's right.
Tell me about the preparation.
So, just like other state health departments, we deal with vaccine distribution, and many of the people who are working with us now on the current plan were here for the H1N1 rollout as well. So had experience in thinking about a new vaccine and how to effectively, efficiently, and equitably distribute it across our state. And, our work at the Department of Public Health has been really embedded in health equity, which is embedded in our mission to promote health equity. And we, for the last 5 years, have been looking at our data in a precision public health way to find out which groups of individuals in Massachusetts are at highest risk for diseases such as, for example, we did a lot of work looking at high-risk individuals for the opioid epidemic. But as we look, Josh, across our different diseases and entities, we find, unfortunately, that communities of color continued to be highlighted as groups that, were the most burdened by disease and illness. And so we really structured a racial equity framework at our Department of Public Health, looking upstream from just the disease and seeing what are the structural and institutional racism factors that come into account and what can we do to start to address that with communities. So if you embed into that our work with COVID-19, it really fit nicely with the work we've been doing at the department.
Got it. So how did that manifest itself? How did that work manifest itself so that you felt that measure of we can do this when you heard about the vaccine?
When we think about our health equity work and we all began hearing about the alarming disproportionate way in which COVID-19 was impacting us all, we set up a health equity advisory group of individuals from community and from healthcare and public health and other experts to help us think about COVID-19. And one really interesting thing is we were hearing about individuals who are more impacted by COVID-19, but we started to look at our data and try and break it down by race and ethnicity, and we found that we didn't have the data that we needed. So for example, in April, we only had 28% of deaths was the race and ethnicity recorded, and similarly, only 45% of hospitalizations recorded race and ethnicity. So here we were at a starting point where we didn't even know what the impact was to different racial and ethnic groups. So then I put out a public health order requiring race and ethnicity data be filled out in these. And now we're up to 98% of deaths reported and 88% of hospitalizations. I raise this because this is, a lever that we could pull at the Department of Public Health. And based on that data and the recommendations of our Health Equity Advisory Group, we then began to lay out the disproportionate impact in Massachusetts. And unfortunately, just like across the country, we see that Black non-Hispanics have a 2.8 times higher rate than white individuals for contacting COVID, and in Hispanics, it's 4.4 times higher. So this began to lay the framework that there are individuals among us who are at higher risk. And based on that, we have done more data analytics and really focused on COVID-19 mitigation that goes to the communities of highest need, and focused on community engagement and thinking about the different social determinants of health as we roll out anything, testing, PPE supplies, and now vaccines. And that's really focusing on understanding that it's not about race, it's about racism, it's not about somebody's biological risk for COVID-19. It is these social determinants of health, like the quality of the housing, access to telehealth and testing, inability to work from home, and exposures related to work, including essential workers. And that was kind of the groundwork for our vaccine work.
How does that then appear in your vaccine work? Do you rely on the relationships you built through that work with the organizations? Like, what would we see in Massachusetts as a result of that, all that focus?
It's a great question. And we have a three-phased approach to distributing vaccine that goes from December, so now, until the end of June, with a goal of vaccinating in Massachusetts over 5 million individuals to reach herd immunity. And so phase one of that, well, I should just back up and say that when we started to look at then how do we decide how we phase out vaccine distribution, we relied on an external advisory group made up of experts and community leaders in order to help us think about, with our internal experts, how this distribution should occur. And, that was really based on thinking about the equity piece, decreasing cases and deaths of COVID-19, and then preserving our healthcare system, which we all know the importance of that. And so based on that, for example, giving you some examples, so the first group, as in many places following ACP and other guidance, were clinicians on the front line. But we didn't want clinicians just to be identified as frontline COVID facing as just the doctors and nurses. So it was the doctors and nurses and the environmental services and the food and other ancillary staff who sometimes are disproportionately drawn from these highly impacted areas in Massachusetts. So we wanted to make sure that everybody in the hospital who was COVID facing was getting vaccinated at the same time. That's one example. Another is that in our phased approach, after we do clinical, long-term care, police and fire and other responders, we then go to congregate care. And we made sure to include in that individual staff and clients at shelters and also at prisons and jails. So we specifically called out those individuals who, again, according to our health parameters, are some of the highest risk individuals. And then the other thing I want to point out is that in phase 2 and 3, we will do an 80-20 distribution. What that means is 80% will go out to whoever qualifies in phase 2 and 3, and 20% will be sent specifically and deliberately to the highest need areas. And the way that we'll do that in our health equity model is that 20% will be determined by the CDC's Social Vulnerability Index, as we map it to Massachusetts, and where we see the highest COVID rates. So when we see those communities, we'll send 20% extra dosing to them because of the disproportionate impact in those areas. So that's another piece that we put in our phased approach.
Could you just explain a little bit about the Social Vulnerability Index, what goes into that?
Yeah, absolutely. So the CDC Social Vulnerability Index relies on about 15 plus parameters that look at kind of the factors I was talking about earlier, right? So poverty levels, employment levels, housing status, and it takes into account how individuals in those areas would be able to respond to an emergency or a crisis. So thinking about COVID-19 as that emergency or crisis, then that Social Vulnerability Index can be displayed on a map of Massachusetts by towns and cities, and we then overlay on that our own data related to cases of COVID-19 to come up with our own index of where that 20% would go. So that's part of our equity model.
Got it. So it's sort of both that you are picking your priorities based on this model that you're using, but also that even within those priority groups, you're trying to make sure that equity is addressed.
Absolutely. So that's really a great way to say it. So thinking about it within the phasing, but also within each individual group to make sure we're really assuring that we're able to think about equity at the forefront. And I will tell you that our external advisory group has been extremely helpful in coming up with that model. And additionally, I do want to mention that as we're thinking about this and talking about this and how do we communicate to the communities about this, we also have set up an external advisory group on communication so that we can make sure that we're communicating how we came up with this guidance and how we came up with this phasing and what evidence it was based on.
Got it. I was going to ask you a separate question, though, about communication, which is you want to be able to offer vaccines, but you also want people to accept the vaccines. So how are you approaching vaccine acceptance within your approach to getting the vaccine out there?
It's a great question and such an important part, right? Because as I've heard others say, we have to vaccinate against mistrust, right? Because it's one thing to have the vaccines, but we need to get them and have people fully vaccinated who need it in order for any of us to get back to some semblance of normalcy, right? It's like kind of a group community effort. And what our approach to that is really based on community engagement. So we are doing a public messaging campaign where we are looking at what will resonate with communities. So first of all, asking in focus groups and community forums, what are the barriers and what are people hearing? So that we first want to understand what individuals are consuming as information and then how we can help them understand what the barriers are and what we can do. So we're doing that. And then in terms of communication to combat misinformation, we are then using community advisors to say, does this resonate? What languages do we need to send it out in? Some people use social media, but a lot of individuals are listening to very specific, say, for example, ethnic radio or television shows, and how do we outreach to make sure that message is going? And we're really relying on local leaders to help us with individual communities so that, there was a survey done in Massachusetts, not by our department, but there was a survey done that said that the most trusted voice for individuals is their own doctor or doctors who are recognized and known. So we are really looking to use the power of that trusting relationship to help explain the facts and the science about the vaccine and dispel any misinformation. But it's really about the community level approach for us to make sure that it's people that are trusted in the community that are delivering these messages.
Well, I really appreciate your taking time out of this incredible, effort to explain it and to walk us through what you're planning. You have been a tremendous leader for Massachusetts throughout this pandemic and well beyond COVID-19. Good luck.
Thank you so much. And thanks for taking the time to talk with me. I'm really proud of our program. I'm really proud of our public health leaders around the country and appreciate their camaraderie through all of this.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, C.N. Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo and Neiman Outland. Social media support from Brenda Haggader, Grace Holes Fernandez, and Caroline Wong. Thank you for listening.